Okay, and then I'm going, okay, it's recording on mine too. All right.
Okay, welcome back to the Moms Ask Why podcast. I am your host, Chelsea Jules. On Moms Ask Why, we challenge the norm surrounding motherhood and ask questions that many of us are thinking but may be afraid to voice. Our mission is to educate, inspire, and empower mothers to reclaim their families and, most importantly, their children's health.
And I'm your other host, Brittany Whitney. Today, we have the pleasure of interviewing Dr. Marielly Mitchell, a pediatric doctor of occupational therapy specializing in feeding, sensory processing, and myofunctional therapy, as well as a recognized expert in sleep and airway health. With a passion for uncovering the often overlooked root causes behind children's challenges, Marielly has dedicated her career to empowering families and helping children overcome barriers to reach their full potential. Dr. Marielly, welcome to the Moms Ask Why podcast.
Oh, thank you so much. I'm so excited to be here.
So a little background, Marielly helped my daughter tremendously. Like her first 2 years of life, Marielly, you were I truly don't know what we'd have done without you. So the second that Chelsea and I were like, we're launching this podcast, I was like, you were one of the first people we reached out to because you were so instrumental in her development and everything. So I'm excited for you to share your knowledge with our audience.
Yeah, absolutely. That's really sweet of you to say. And she's flourishing. So I'm really happy to hear about that too. So yeah.
Yeah, and you fit in so perfectly with everything that we're talking about. Like, we really want to educate moms in understanding that they have different options like what you provide. And I think a lot of moms don't even understand that this is an option to go through the process of the service that you do provide. So I would love to hear if you could kind of explain what your journey was to opening Theraplay LA.
Yeah, absolutely. So, yeah, like you said earlier, I'm a doctor of occupational therapy, and a lot of moms know occupational therapy, speech therapy, et cetera, and PT and things like that. Here at Therapy LA, we do OT and speech services, but really when I founded this company, I don't even know, like 13 years ago, I graduated from USC in 2011, so a while now. I've always been kind of one of the clinicians that, like, if there is a box, I'm thinking outside of it, but that's how much I'm really trying to uncover what's going on with the child and the family that I'm working with. And so we use a really integrative approach. So we do, like you were mentioning earlier, a lot of the typical sensory motor approaches of giving the child the sensory needs that whatever their sensory profile is telling us, but also motor acquisition, integrating those primitive reflexes, et cetera. And really focusing on the neurological side of things, but then really also focusing on the biological aspects of things. So I know that you're really into nutrition and feeding, and that's something that was a huge passion of mine the first portion of my career. And that led me into the mouth area, which then led me into orofacial myofunctional therapy. I also pursued an SWC, which is like an advanced swallowing degree in my profession. So you take like an extra 5 years post-master's work. And I really started seeing the mouth as a portal to health. With that, I learned a lot about breathing, and then I learned a lot about how that impacts your nervous system. And then when it really blew my mind is when I learned about how much that impacts sleep. And then I started correlating how children's breathing patterns and sleeping patterns are exacerbating the neurological and psychological symptoms that I see in my clinic day in and day out. So we really try to get to the root cause of honoring the biology and physiology before we go into the neurology and psychology.
Okay, so Marielly, for those who are listening and are like, what the heck is a myofunctional therapist? Like, dumb it down. Like you're talking to a fifth grader, what do you do?
Yeah, so myofunctional therapists specialize in really working on the oral rest posture of the mouth. So the basic rules of anatomy are that your tongue should be suctioned to the roof of your mouth at all times, unless you are speaking or eating. That is how we are anatomically built. And so when your tongue isn't suctioned to the roof of the mouth, there's a lot of things that can kind of go awry when you start to mouth breathe. And that makes you, not only are you that child or person ingesting germs nonstop, because you have filtration systems in your nose that you don't have in your mouth. That puts that nervous system into a state of fight or flight. Your brain perceives mouth breathing as gasping, which really is dysregulating, and it translates into sleep. And then you get lighter sleep and it's less restorative. So myofunctional therapists, what their goal is to get the tongue suction to the roof of the mouth for proper oral rest posture. It's kind of like when you make that sound, but before your tongue hits the bottom of the mouth, and it stays up there. And then they support that. The nose is the one doing all the breathing. And your tongue is your natural expander and retainer. So this also facilitates
Interesting.
posture and airway architecture for the development of your craniofacial bones, which is your face. Does that make sense?
Yeah,
That is so interesting to me because
I know.
the way you explained it of like, it's like a palate expander, right? Like every child ends up with a palate expander. And if we were to just breathe the way we're supposed to, are you basically saying that like probably most kids would not even necessarily need a palate expander if they were taught how to breathe properly and sleep properly?
Yeah, and so what happens is that like in the United States, unfortunately, this is like a system issue, but there's not enough maternity leave, there's not a lot of support for breastfeeding and things like that. And this is all about physics. It's not about any type of like choice anyone makes. It's really about just how physics works. So you know how some children, if they're on their back for too long, the back of the head gets flat, and then we're looking at plagiocephaly, helmets, etc. The mouth is no exception to that role, but you're at more mercy of soft tissue because there's no hard bone there. So whatever goes into that child's mouth when they're really young, because they're like Play-Doh when they're born, their oral cavity will form to that. And unfortunately, bottles and pacifiers separate the tongue from the roof of the mouth. And there's a nerve there at the roof of the mouth that is really calming and soothing called your nasal palatine nerve. And it literally helps people secrete dopamine and serotonin. That's why like a child will suck their thumb or they use the pacifier and their eyes like literally roll the back of their head, and parents are like, oh my God, like they're going into a trance. I'm like, no, they like literally are. And it's like, you know, some kids have a hard time getting rid of the pacifier because it's like it really soothes them. And so it also gives that deep pressure that all the OTs talk about, like deep proprioceptive input. Well, your tongue is like your free organic weighted blanket in your mouth with all these nerves, but not everybody uses it effectively. So if we had in an optimal development in that sense with if we seize bottle and pacifier use by a certain amount of time and then have proper oral rest posture, that's going to facilitate palatal expansion, tongue placement, and the upper jaw and the lower jaw, the mandible maxilla, will have a more harmonious relationship. But for me, what I care most about is that the jaw grows forward and widthwise, because the jaw is a reflection of what's going on with your airway. And we notice things like teeth more cosmetically, but that shows us that there's too small of a jaw, which means there's too small of a airway as well. So those are but to answer your question, yeah, we would essentially with proper oral rest posture, it would really facilitate a lot of things in overall child development.
That is so wild. So let's say, as you know, when you worked with me and my daughter, she was a chronic passy user and she used it till age 4. And we have a lot of work to do, but she still mouth breathes. So for a parent that's listening and doesn't like, if they thought, oh my gosh, my child snores like a truck driver at night, it's so cute, it's so funny, like that is a sign of oral dysregulation. So kind of explain how maybe they think their child's getting a great night of sleep, but they actually aren't.
Yeah, so that's a really good point. So a lot of the symptoms that we look for with when it comes to myofunctional therapy is we're screening for airway issues and orofacial, which is oro is mouth, facial is face, and myo is muscle. And like you said, like a lot of parents are like, oh my gosh, like they're snoring like a truck driver. And so it's so cute. They snore and it's like this little sound, and it's like snoring as I guess as acute as it can be, like it really should be kind of like investigated. And a lot of these symptoms, unfortunately, they're really common, but they're never normal. And I want to really emphasize that just because everyone else's child isn't sleeping, that doesn't mean that that's normal. And I think that's something that as a society, we've really normalized a lot of the time. And we really want to make sure that children are getting optimal sleep, because when they're sleep, it's kind of like hair. Like if your body doesn't get the nutrition that it needs or your hormones are off, like women can lose their hair, right? Or men can too. If you don't get good sleep, your frontal cortex, which is responsible for impulse control, attention, self-regulation, emotional regulation, organization of behavior, like that goes out the window. Like it's your body's kind of like, I don't have the energy for that. And so you're already dealing with a mind that is developing, and then they have this like insult biologically where they're not getting enough oxygen that can really impact that. And so snoring, grinding their teeth, waking up at night, if they're potty trained and then they have a regression with potty like training and they start to wet the bed or wet themselves during the day, that's also a sign. It's kind of like when someone has sleep apnea and they wake up to use the restroom a lot, that's a big sign of that. These are all, again, really kind of common things that people don't really realize is a person struggling to breathe and struggling to get good restorative sleep. And then the intensity of whatever sensory stuff they've got going on, if they're a child with an unintegrated nervous system, can really get a lot more intense. So my sensory seekers will seek more. My sensory avoiders will avoid more. And then some of the kids kind of just go through the cycle, like so many cycles. But yeah, it can really impact the symptoms of what they're seeing in sleep, as we call it sleep disordered breathing. If they hyperextend their neck when they're sleeping to try to like open up their airway and breathe more. Or they wake up a lot and have like night terrors or wake up really upset, that's telling you that the nervous system is dysregulated at baseline. And that's something that is really, it's unfortunate because then some kids get this vicious cycle where they can't verbalize it. Some kids, my like 9 to like 12-year-olds will say like, I don't like sleeping because they're kind of scared to fall asleep. They can't put their finger on it, but it's because it doesn't feel good. And so then they get this like vicious cycle that there's almost like a fear because they can't downregulate to that sleep. And then that can really, then it's this vicious cycle of not wanting to sleep, but the sleep that they even get is not good quality sleep. And that can really wreak havoc on the nervous system. And so there's lots of symptoms to kind of look out for in that regard. That's what we do here.
I love that you mentioned the nervous system because I feel like a lot of doctors, and it's not necessarily always recognized, right? Like the fact that you're mentioning the nervous system and you work with a lot of kids that are on the spectrum, right?
Mm-hmm.
Those tie into one another. Do you feel like when you are working with these kids that are on the spectrum, once you address the nervous system in the work that you do with myofunctional therapy, do you see a decrease in the symptoms that they're exhibiting?
Oh my God, yeah. Like it was revolutionary for me as a clinician. And just so you know, like I'm like a patient and also a practitioner. I've had my own myofunctional therapy challenges. I've had a septoplasty. I was a mouth breather when I was younger. I didn't get good sleep when I was a teenager. I've had multiple laser treatments in my tongue in an area to help with, and I've also had orthodontics and I'm going back into it. So I've also lived it, not sleeping well and then getting better sleep. But for my children, especially with ASD or my kids with ADHD or ADD or like neuromuscular and coordination or sensory things,
Mhm.
when you open up that child's airway, and look, I'm not saying it's like, oh my God, it's done, it's quick. I was only one day at the
Yeah.
visit dentist. That's not it. This is
Yeah.
it's a journey, just like a lot of things are. And with children, a child is a journey, really what it is. But this is part of that journey. What I have seen has like really revolutionized like my perception of what I do to the extent of how drastic the results are. And I'm talking about kids who go and get like, a child comes into my clinic for an evaluation. And of course I look at all the sensory systems. Like, do they like swinging? Is it vestibular, proprioceptive, jumping, crashing, tactile, ball pit, all that? But if I open a child's mouth and they have huge tonsils, like it doesn't matter if I have a swing from 2050, like it's not going to work. And like the therapy will not penetrate, those sensory systems will not activate. And as soon as you open up that child's airway, and sometimes you need to have surgery, you do. And we always try to avoid it a lot of times, but usually within 6 months we have to, again, especially if a child's really inflamed. By the time the tonsils nowadays get so big, it blocks the airway. And when you open up that child's airway, either with that kind of procedure, if necessary, or expansion through dental work, it unlocks them. It is their sensory like seeking behaviors become so much less. They are all of those executive functioning skills that I talked about, impulse control, attention, regulation, etc. Everything starts to fall into place. Their tantrums go down. They just kind of are able to regulate themselves. They get better sleep. And I think as a society, none of us really understand that very well. And you have to remember, we're also on like the cusp and the precipice of really understanding sleep with the technological advancements we've had in the past decade. So I feel like we're just scratching the surface with this. But kids, especially on the spectrum, when you open up their airway or even close their mouth and get them to breathe through their nose, they're not trying to regulate themselves all the time. Like a lot of my kids who are putting things in their mouth constantly are seeking sensory input for what their tongue used to do. And they're in a sympathetic tone because they're mouth breathing. And then they use a munchie and they're munching on it more and getting more dysregulated, right? You have to close the mouth and get them to breathe through their nose. But I've seen tremendous results with children whose airway we open, and biology just starts to fall into place, and they are like not in this also hyper-inflammatory response. Like that's the state. What happens is when you're mouth breathing, you're fighting bacteria, viruses, all these things, and it's not helping anything work. So it really has a ripple effect that is like not in a positive way. And so for my ASD kids, the way that the mouth impacts their function is really, really, really important to address, because you have to also remember those children are typically really visual, like we all are. We're really visual beings. It's the one body part you can't see. You have to go off of sensory perception. And so a lot of these kids are constantly putting things in their mouth or not putting things in their mouth that they don't want to. So they have this like disconnection from their mouth that they haven't figured out how to integrate and coordinate and think about speech. Speech is like coordination of these muscles that they can't see, and then cognitive thoughts included. It's so many levels. And if they're not even breathing correctly or have their tongue in the right place, it's hard for them to just put that all together. So when you start to do this stuff, they just kind of like unlock in a lot of ways, which has been really beautiful to see. And if you know that there's a blocked airway, I mean, so many parents, I've never had a parent like regret doing a procedure like tonsils or adenoids, and that is kind of like a more drastic thing, but they're always like, I don't know why it took so long. Like why, like now that I'm on the other side of the procedure, they're like, oh my God, my child is so different. I'm like, yeah. And it's pretty drastic pretty quickly.
So does that start with you? Like, do they have the suspicion, they come to you and then you refer for a procedure like that? Is that how that works?
What typically happens in my world is that a child will come to me and they will usually have some type of, there's a reason for a referral. Like maybe it's behavioral, maybe they're biting peers at school, or they can't pay attention. And like, usually schools flagged it and something's going on there. Can't sit still. They have poor impulse control. They're so anxious. They can't regulate. They're crying all the time. They're really upset, or they're not sleeping. They come here, and as a traditional OT, I look at the OT side of this stuff, what's going on sensory wise. And then I will always, this is the myofunctional therapist in me, that I will look in their mouth, check their airway. What is the anatomy of the mouth look like? And then if I suspect a blocked airway, I will refer to I'm really lucky to be in LA, where like the mecca of airway, like sleep doctors are. I will refer to an airway centric ENT, and then we'll get that screened and looked at, and then he'll basically tell me like, oh, that like there's definitely a blocked airway here or not. Or thankfully he collaborates with me a ton, and I'll give him all the context. Like this kid's waking up 7 times a night, grinding their teeth. They can't pay attention at school. And it might be like a borderline case where another ENT is kind of like, no, we're going to wait and see. And I'm just like, but he'll listen to the whole story of what's going on. And like, I wish more surgeons would like be more qualitative in that way, because it's not just about like how much, it's about like how much is this blocked about, how much is this impacting this little person and their family. Because you have to remember, like, if these kids aren't sleeping, like these moms aren't sleeping, these dads aren't sleeping, like someone's not sleeping because that child is going to them and or screaming or disrupting it, or they're losing sleep over this child. It either however you slice or dice it, someone's not sleeping that's caring for them. And so that's typically how it works. And then I will often refer to in conjunction, and we usher families through this process because it is a medical thing. We're like a family, she said, how does mom put it? She's called us like her North Star. We usher them through this process of the medical and then the dental side of it. Because once you fix the anatomy and open the airway, you have to adjust the rest of the craniofacial bones to follow. And then we do the therapy to close the mouth. But if there's a blocked airway, we can't. Like some parents come with us and they're like, I don't want to get the tonsils out, but like, can you do therapy? And I'm like, no, like there's nowhere this kid can't breathe. Like there's no way. And it's kind of someone has to kind of bring the reality of it. Like this child's suffocating, truly. It's a harsh word to use, but it's the truth. Their airway's completely blocked.
It's so true. And it hits home for me so much. Marielly, I think we need to pick up our Zoom sessions again, because I'm the parent with no sleep. And my daughter comes in every night looking for us, and I hear her and she's literally choking in her sleep. And we've ditched the passy. And I know I've been putting it off. But I remember when I spoke to you, you said something so interesting where the child's jaw, when is it basically almost developed by?
Yeah, so by age 6, about 80% of the child's jaw is developed. And that's why we're no longer waiting until they're 10 or 13 to do orthodontic intervention. I mean, at the clinic, we use this thing called a mild munchie, which you can find on my Instagram and stuff, but it's this like little chewy. And this is something that we talked about, I think, when we were working together. And I was like, let's try to move them from the passy to this, but it's different. It's not like a sucking pattern. It's you munch on it. And there's a window of there's a window between like 6 to like 12 months where they start to munch. This is like, I just know the rules of development. Like that's how but there's a window, it's a sweet spot, and they want to munch on things, and you can use this. And this is the earliest, not really a true orthodontic, but mouthpiece that you can use where things will open up. And it's really amazing to kind of like be able to change things so early on. And that's why we are doing orthodontics as super, super young. We're even doing stuff with like some of the dentists I work with children with specific syndromes like Down syndrome. We're doing orthodontics like as soon as their molars come in, because we can change the trajectory of their face and their airway, and it truly changes the trajectory of their life. Good quality sleep. Like there's a longitudinal study that they did on children who I think were in kindergarten who had sleep apnea, and sleep apnea is, a full-on diagnosis, but sleep disordered breathing is you're on a fast path to sleep apnea. That's what that is. They were 3 times more likely to have special needs placement within like 5 years of following these children. Like that's how serious sleep is. And I think and so now we know that. So dentists and orthodontists are working with like kids who we know their craniofacial structure is going to compromise their airway. And it's amazing with those kids. They're doing so well because they're breathing and sleeping and they're not snoring. And it's been really fun and like amazing to be like on the edge of that. And I wish more people incorporated it because it's really important. It makes everyone's lives easier.
Yeah. And if I could tell any mom one piece of advice, if they have a passy obsessed child, like we did the taking care of baby sleep thing, and she said to put 12 passies in the crib so they can always find one. At that crucial time, swap it out for the mile munchie and get their jaw moving, because once they get so addicted and you're just like an exhausted parent, you give up and you just give them whatever they want. So I think hopefully a lot of new moms too can listen to this and kind of
Yeah.
gain some
Yeah.
insight.
No, absolutely. And the mile munchie, you want to start, like I always tell parents to kind of use it as their first utensil when they're sitting and just like playing with purees and just having to munch on it and make it easy and things like that. And then wean off the passy when you can. The mile munchie, you have to have like the blessing of a dentist to use it like at night and stuff. But ideally, if that child's mouth was closed, and also you have to kind of like look at the whole picture, right? Like if mom is like super tired, has to go back to work, doesn't have maternity leave, and she needs to use the passy, like she needs to use the passy, like she needs to sleep, like baby needs to sleep. I'm not here to be like shaming passy use, but like there is a balance that you can have that where you can wean off of that, especially at 12 months. And you can like you can use the munchie as young as 6. You have to be with the clinician, but that like transitional period will really do such a positive long-term effect on that jaw, that airway, and then those sleep patterns. And it'll really, really help in general. So yeah.
No, that's such great advice. And now I kind of want to segue into eating because it all goes hand in hand. Can you kind of explain, let's say a child is mouth breathing or they have like no air through their nose, right? When I'm sick, for example, if I'm breathing through my mouth, I am cranky, I'm pissed off, like I don't want to eat like the nutritious foods, like you know what I mean? So I think a lot of parents can think of it that way too. When you're sick and you're so clogged, it's hard to sleep, it's hard to eat. Like, can you kind of go into that and explain that?
Absolutely. It's also really hard to swallow when you're
Yeah.
like sick. And that goes back to like the tonsils. Like, I will touch base on all the other factors of this, but I mean, we have multiple times now at this point, I've had like 4-year-olds, 7-year-olds, 9-year-olds have their procedure and they're like, it doesn't hurt to eat anymore. It doesn't hurt to swallow. I can eat chips. And I'm just like, oh my God, it was painful. Like I still get really like kind of like feel like I get hit by a bus some days when kids tell me the things that happen when you open their airway. Like we don't realize how uncomfortable they are because they don't know either because they've never felt anything different. And that's something that's really important to roll out with selective eating. But when you're mouth breathing, absolutely, you're already cranky because you're in a state of fight or flight. You probably weren't sleeping well because your mouth has been open. And what also is happening is from a biomechanical perspective, I like to call the tongue like the core of the face and the jaw like the hips. And it's kind of like as if you haven't done squats in a really long time, then all of a sudden someone's like, drop and give me 30, but like with like bands on. And that's like, a piece of steak. And the kid's like, no, no way. And so it's the person just literally can't do these things. And if you have an overbite due to, your anatomy and the back of your molars don't touch, how can you like bite and tear and shred anything? And that's why kids want to, use the suck on the pouches. They want to eat thing that always has the same texture. It's less motor planning for the mouth. They want to just chew on the things that they can chew with their frontal teeth or just on the side, right? And munch on that. And so oral motor skills are really complex because again, it's the one body part you can't see. You should always, if you have a child with any sensory processing challenges and you're having any issues with feeding, I always encourage parents to use a mirror with them. That visual feedback is really helpful for kids. And also teaching kids their anatomy, like education is empowerment. This is your tongue, these are your teeth, these are your chewing teeth, these are your lips. Trying to teach them to chew with their mouth closed. If they can breathe through their nose, if they can't, then I wouldn't push that. But empowering them with labels and being able to like identify and then coordinate those parts of their body is really important. But so much of eating is related to what your mouth can do. And if you've got a child who has, a speech delay or was drooling for a long time or is mouth breathing or was historically has been mouth breathing, like, that there's something going on with that jaw, that tongue in general, and that's going to impact the coordination of that. And then you have to remember motor planning is you can have motor planning without anything, which is like me walking, right? I have to motor plan that, or when I walk upstairs. But when you have like a ball coming at you, or you have a ball of like food or like a tater tot in your mouth, that's something you have to motor plan around. And the more complex the food is and the texture, the more motor planning and sensory processing that requires. And that's really hard for a lot of kids. And that's why they want to eat the same things over and over, or macaroni and cheese. It doesn't require a lot of chewing, doesn't require a lot of strength and endurance or coordination. They can just swallow it whole too. So it's very feeding. I really always want parents to realize that the anatomy has a lot to do with it. And we've had a lot of kids who go in, or I'll say like, okay, you're here for feeding. They're older, right? And their mouth is just anatomically really not where it should be. I'll actually tell them and send them to dental first. And I'll say, I really think you should get expanded first and let's get you an orthodontics. And their diet will organically start to just change in the time that they weren't even in therapy with us. And they'll come back and their duration in therapy will be much shorter than it was, I think, anecdotally, than it would have been had I started them off the bat with teeth that couldn't even touch. Like I have kids who can't even bite an apple or like anything because the teeth literally won't connect. So yeah, it's really complex in that way.
I have a question because I have a million questions, to be honest. You are like blowing my mind with everything that you're saying. I'm like, don't forget to ask this and this and this. So I have so many questions. Number one, I think I would love to know like what exactly does therapy look like with an occupational therapist that specializes in myofunctional therapy? Because I'm very familiar with OT evals and, evaluations, school-based OT and home-based OT for like, what is the occupation at home? What is the occupation at school? And that's what we typically target, with
Mhm.
our OT, with our goals,
Mhm.
professionally for me and also with my own kids. So I'm curious, what does that look like? How is it different, I guess? And what does
Yeah.
the therapy like look like? Like what exactly when you're working with a kid, like what does it look like?
Yeah, it's a really good question. So when a child comes here, basically they're getting OT, but they're getting a really like blended type of therapy that's kind of like niche to us in a way, but also there are OTs who do myo. So I can't speak for all of them, but this is kind of like what we do. So I have a process with the different kinds of trainings that I've done and things like that. Basically, they're doing traditional occupational therapy type of activities. So that could be obstacle courses, crossing midline with like, putting the banana in the monkey's mouth on a platform swing or whatever, or, handwriting or coloring, painting, Play-Doh, insert some type of play-based activity with a motoric type of output that you're looking for. And usually like my therapist and I have trays, and we're literally like in kids' mouths and in their noses while they're doing things, trying to get their tongue to, and we're constantly educating and cueing kids to get their tongue to the spot. Most of our sessions in the first like 6 weeks with the child is just anatomy about education of the mouth. This is with the families who are super into the myo and things like that, but we're always educating, and then with the mouth and teaching kids like, hey, like, this goes a long way with like a 7-year-old boy. I'm like, buddy, like there was a baby here, like you're eating old farts, like that, think about that. And kids are just like, and they close their mouths immediately because they're like, oh my God, you're right. And I'm like, I don't make the rules, man. Like this is how this works. And then they're just like, they kind of care because like no kid should have to care about this stuff, right? And we have to kind of like intrinsically motivate them. We want them to not get sick. They don't want to get sick. Like and sometimes these concepts are too difficult for some kids to understand. They're like 2, right?
That was my thought too. And also a lot of kids on the spectrum struggle with receptive language. So I was going to ask that as well. So I'm glad you're going into that.
Yeah, so we have some books that we read. We also we have puppets that we use. We do a lot of education to the mouth. We're showing them. We also will basically, some of our kids like are so sensitive in the mouth, we have to desensitize that first, because you have to remember like a lot of kids where the tongue doesn't suction to the roof of the mouth, the gag reflex can get kind of like stuck somewhere and it can get really sensitive. And those are for my kids who are like, don't like brushing their teeth, they gag when they're eating, or if like the food moves in an odd place, they're kind of like, they'll gag very easily. And so that I can't just go in and like assault someone's mouth with like a vibrator. Like that's not cool. And so we have to make sure that it's not a super sensitive kid. And just like any sensory profile, we have our super sensitive people and then people who are seeking things, right? And so our sessions are very a blend of activating cranial nerves in the face that control the tongue and the nose with sensory stimulation. That program is kind of like unique to each child of what we find in the evaluation, while they're doing sensory motor based activities that are more gross motor, fine motor, like primitive reflex integration type of things in their session. And then and that's kind of what we're literally like in their mouths while they're doing things, or we'll have like they're throwing bean bags on a platform swing, working on hand-eye coordination and vestibular processing, but we'll stop the swing and get in their mouth, or we'll have them sniff something. Our older kids are often mouth taped, and they're doing a lot of more complex coordination things, or we're working on executive functioning and their tongue suction to the right place, or we have a kid holding like a tic tac because that's like a weight for the tongue up against the roof of the mouth on the spot. Kids will be doing their whole session with the mild munching in their mouth. So it's integrated into our therapeutic process. Usually myofunctional therapy, you have to like sit at a table, and like, which the irony of it is that all these children who have myofunctional challenges are typically really dysregulated.
Can't sit at a table. Yeah.
Can't sit at a table. And I'm like, okay, that's why everyone says you can't do it with the kids under 4, but that's like what we specialize in. So that's like where we're like, we kind of take on those children and really work at it. And, it's amazing because it just, once you get that mouth closed, everything gets easier. Everything gets easier. There's so much more. I mean, we just even see anecdotal things like they start catching better. They're more available to process whatever we're trying to do to them. So that's kind of what sessions look like.
I can attest. I mean, you started working with my daughter. I don't even know how young she was, but she was young. And Miss Rainbow, the whole thing, like it was a puppet show. I mean, it was COVID, so we were doing it over Zoom, but you sent me this whole toolbox, right? Of like the Q-tips, the smelling things, the mouth vibrator. And Marielly has such an art to like, okay, she was like, okay, now like put that in it. Okay, now like do this. Like you pivoted the session so fast that like she was like, oh, okay, like happy the whole time,
Yeah.
That's an art.
Yeah,
it's like
art.
Miss Rachel on steroids, like doing a session with you. It was, you had the puppet, you had the thing, like it was so fun. But
totally. Yeah, it's an art, and we're literally like, we have these trays and we're running around with them and we're like getting in their mouth, and I'm looking for their tongue to like, and we're like, yeah, up there on the spot. And like some sessions are like sitting in a ball pit and we're like, this is your tongue, and we're reading books about the tongue and where does it go, and like your tongue's like, we call it the car, and we park the car in the garage and for our little boys. But yeah, and during COVID, it was even like, I mean, I had never been stretched creatively like that, but it's true. Like I had to puppet everything with and oh my God, Elaine took so well to it, you know, but
Yeah.
it and those sessions are kind of what inspired us to kind of do that stuff here too. Once we started seeing kids in person, but it's you have to as a clinician, my job is to find what's the best way that this child can learn. Because if I can't figure that out, I don't know who's gonna figure it out. So I use whatever I can to make that happen, whether it's
Yeah.
stories or puppets, anatomy, and also for parents too. But everyone's visual.
Yeah,
Everyone's
no,
visual.
you did such an amazing job. And when you said mouth tape, that just reminded me of something that's slightly off topic. But let's say, because mouth tape, there's such a buzz around it, right? There's all these new mouth tapes out. I feel like it's like the buzzword of 2024, one of them in the health community.
Yeah.
Um, let's say that someone's husband, for example, or like their teenage son is snoring, they're mouth breathing, and the parent just slaps mouth tape on and doesn't do actual work. Like that is literally, quite literally putting a band-aid over something to fix it, right? Like that's not getting to the root cause, right?
Yeah, absolutely. And I would also advise people not to do that because if that person has enlarged tonsils, like you're suffocating them more. That's the only
Right.
way that that person can breathe likely. And that's why you always want to get clearance from an ENT, an ear, nose, and throat doctor to make sure that you are a candidate for mouth taping. If you get that clearance, then you can do that. Mouth taping, some people, it is like a band-aid for them. And some people just have like weak jaws or a weak tongue, or they like never really knew that and they have really good anatomy, and that's like fine. If they didn't have braces or they had braces and they never relapsed, okay, your tongue has enough room. But if you have your teeth don't have any space, or you had your wisdom teeth taken out, or you have TMJ issues or things like that, I wouldn't just try to mouth tape. Like definitely not. Like that's something that you might be doing yourself like more harm than good. If you are doing it and you feel the benefits of better improved restorative sleep, then that's great. But yeah, it's you really want to get airway clearance, and it's huge in the biohacking world. And essentially kind of like what we're doing here is like baby biohacking at my clinic. Like I'm making sure that we have everything we can to optimize this nervous system, right? And the biohackers, we have a lot to thank for the technology and the research that's gone into this stuff because they really funded it. So, but yeah, it's not something you want to just slap on some mouth tape and call it a day. I would say, if anything, you can start by like when you're as an adult, maybe put like a tic tac on the roof of your mouth and with your tongue and hold it up while you're driving and do things while you're conscious. Definitely not while you're sleeping. And the ENT, yeah.
Yeah. Totally. I wanted to ask one more question too. Like, let's say a child has low muscle tone, right?
Mhm.
Which I know a lot do, like in the autistic community too, and just in a lot of kids, if they have any sort of underlying issue, like my daughter, for example, has low muscle tone. Um, that kind of impacts the tongue having low muscle tone. Is that correct?
Yeah. Yeah. Low muscle tone really doesn't have any bounds in that sense. So low muscle tone can be global, and it usually is. And your tongue is a muscle, and actually has four muscles in it. And so the thing is with low muscle tone is that it really makes it hard for things to co-contract. So everything we kind of do is like a co-contraction. Sitting up is a co-contraction between your trunk extensors and your back extensors. Your tongue elevation, suctioning into the roof of your mouth, that's a co-contraction of your tongue. Holding a pencil is a co-contraction. That's why for our low toe kids, those are some of the harder things. Or you'll see them W sit or sit with like a curved back posture or kyphosis. And so you really want to bring a balance. When you have low muscle tone, you combat that with building strength and endurance. That's what you want. And so low muscle tone, as much as it is, a diagnosis, there is a path to turning that, still being able to do what you need to do. And that's by really working on strength and endurance. And the mouth is no different. Again, like it truly is like the core of your face. Because if your core is not activated, you're kind of like your posture tight starts to go. If your tongue's not activated, the posture around your tongue, which is your airway, your nose, because the roof of the mouth is the floor of the nose, all of that starts to collapse on itself. So yeah, it's definitely it's not, it has no bounds, but you can combat it.
So let's say a mom is listening and they're like, great, my child mouth breathes. They have poor attention at school. And let's say this mom feels completely overwhelmed and like doesn't have a great budget, right, to like hire private therapists or whatever. What is the first piece of advice you would give that mom who's just completely overwhelmed and like doesn't even know where to start?
Yeah, I would say it depends on like her location. And what I would do is I would go on to airwaycircle.com and I would find, and this is a network of people that I'm connected to, and I would find airway centric people who are in your community. They will likely also be private because to be honest with you, the amount of training that this requires post your just whatever your profession is, whether it's speech therapy, which is usually where myofunctional ends up, or dental hygienist. It's like OTs are kind of rare, or the ENTs, even because now they're getting into sleep. A lot of these people are just kind of like out of network in that sense, but I would find those people, do a consult and have them make a plan for you, and then try to go in network to find clinicians that have the training that you are looking for, and or at least the evaluation from an ENT. I would start with getting like a really good evaluation by an ENT and seeing why is this child like snoring, why is their mouth open, and finding one that's airway centric. Because not all ENTs, just like not all speech therapists, not all OTs are created equally. And you want someone who's going to really take the mouth breathing seriously. And then you kind of consult with people who are that have this type of training, and then kind of piecemeal your team as best as you can.
Yeah,
So
and you have a ton of free resources, right?
yeah, so I have a ton of free resources on my link tree on my Instagram. So my Instagram's Dr. Marielly. It's spelled out DOCTOR and then MARIELLY. And on my link tree, I have like a free screener for parents to see like, is my child displaying like signs of sleep disordered breathing? My favorite reasons for the mild munchie, which is really helpful, and kind of like where you can buy one. And then also like strategies to help calm your child down in general. So I've got lots of resources, and also kind of what questions to ask the ENT. So literally a notepad for parents, like ask these questions, see what they say, etc. And yeah, I definitely have a lot of resources like that, because people, it's a really complex type of facet of development, but it impacts everything. So it's interesting. Like, I have a lot of my patients that I consult with, or parent coaching that I do, are usually like therapists, like speech therapists, who just realize like my kid has a ton of myo issues, and they're having trouble understanding everything. Can you imagine for like a parent who's not, educated in like some type of expert field? There's just a lot of cooks in the kitchen, because other than a woman's reproductive system, I don't know another body part that does more. Chewing, swallowing, breathing, tasting, all the things. There's so much going on here. And that's why you need like dental, ENT, the myofunctional therapist. Like there's just so much that can go right, and also that can go wrong. And it has a ripple effect. That's the issue, is that if one thing starts to teeter, it starts to impact other things.
And Marielly, you're in LA, so if anyone wants to look you up, and you have a team of therapists to work with,
Yeah.
if one isn't going to work with you specifically, you have a whole team. You have
Mhm.
some new innovative laser technology. Can you talk about that really quickly?
Yeah. So yeah, to piggyback what you said, we're in LA, we have OT, and we also have a speech department. Everyone in the clinic is trained in myo. That's like what we specialize in. And so we just kind of see like, does a child have like a stuttering challenge? And then then we'll do speech. If they have regulation or like motor things going on, then they'll do OT. It just really varies in that way. And then yeah, we're going to be bringing in a new intensive department, where it's strictly going to be, we do them already, but we're going to be doing intensives with specific programs. One of them also being like low-level light laser therapy, which has been showing really amazing results, especially with our children on the spectrum, that have been being used. And we're seeing amazing outcomes with all sorts of programming that is added to that. So primitive reflex integration, using things specifically to work on vagal tone. I'm sounding really nerdy now, but like your vagus nerve controls your entire nervous system of your fight or flight, parasympathetic kind of tone in that sense. And so basically creating a program specifically for that, that's not really traditional in the box OT, and making that only like through intensive models, because I wish everyone could do them, but intensives are really the way to go. Everyone in therapy, the reason why we have jobs is because neuroplasticity, and the more you do something, the faster it'll come. So yeah, I'm really excited about that for 2025.
You're
I
barking
have a
up the
quick
right
question.
tree.
Yeah.
Is that different or the same as MERT therapy? Have you heard of MERT therapy? And is that similar or no?
MERT. I don't know if I don't think it's MERT. Is MERT, do you know the acronym for that?
I was literally just going to say, don't ask me for the acronym to that. I do, I do know it, but I don't want to butcher it. But it's essentially a laser treatment that they are starting to do on kids that, are on the spectrum, and essentially is supposed to.
Oh, so actually MERT is, so this is actually really exciting. So you're talking about like magnetic electronic like type of conduction. So this is actually
Right.
something I'm starting with lasers because I feel like people are more primed for this, but I actually am looking into bringing that in like later in the year
Okay. Okay.
2025.
Very cool.
Because it is, I mean, I'm a total gadget girl. I've always had like, I've go to dental conferences. I always buy the laser. I'm really into like lasers. I've just always been the person. I bought like a 3D TV before you should even like do it. Like I've just been into tech. And so I've just been waiting for my field to like get it together with lasers. And now it's like, people are starting to do it. And so, but what you're talking about is really amazing with magnetic, basically electronic type of stimulation, but essentially both of these modalities are essentially encouraging the brain to conduct. And what we're seeing with this is incredible. I mean, not even in just pediatrics, but also with adults, in the sense that this type of stimulation is really helping the brain do what it needs to do. And you're truly like just like stimulating and waking up parts of the brain that we're trying to do with like sensory brushes and like vibration
Very
and all
cool.
these things. But now what I'll be doing at my clinic is kind of like putting all of it together and
Love
it's
that. How
airway and
cool.
issues. And yeah, but that's going to be its own like department of therapy. And I'm like so excited. I personally haven't been this excited about something professionally or personally since I learned about airway stuff like 8 years ago. Cause I'm just like, my jaw was on the floor when I was like seeing what videos and stuff like that. Like I was just like, excuse me. So I'm
That
really
makes me excited that you're excited about it because I know this is kind of new, especially to like a lot of moms that have kids that would consider something like myself. You know, I have two boys that I would consider doing something like MERT therapy with. And it's so new that you're like, well, does it work or does it not? So for me to hear you be so excited about it is just so cool.
yeah, and they've been doing these things like not really like publicly for some time. And there is a lot of in the adult world, they're using like it's called TEMS. It's like trans electrical magnetic stimulation. And so it's like a paddle that like kind of goes around and same thing. And it's that's what we're looking to bring it into. And I mean the outcomes, like the research from Stanford and all of that stuff that's aligning with it, it's really amazing. And so myself and some of the pediatricians that you know over here in LA, like we're really, really excited about it because it's gonna in my opinion, it's gonna revolutionize what therapy can do, and it's gonna shorten the amount of time. And I think it's gonna hit so
Wow.
many of the factors that impact the ability of the brain to conduct as it should. And I don't think it's automatically gonna help people sleep, but that's my job to help them sleep and do this kind of stuff. So yeah, I think there's a huge I think we're like on the cusp of that. And I think parents are also starting to realize that um with these technological advancements, like there's nothing to lose. Like they've been around long enough now that they've seen adults getting these treatments, and it is really kind of pushing the envelope in terms of like for pediatrics, but their traditional stuff's not working. I mean, who like truly like, kids are, yes, we're gonna have some kids who will be, needing support for their entire lives, but like there's a lot of kids that like, I think that's why OT and like speech sometimes gets a bad rap. And it's like, and I'll speak on behalf of my like profession on that, but like kids are in OT for 7 years and people get so burnt out and they're like, it didn't work, this didn't work, and da 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 da. And it's because like there's other things that we have to start looking at. It's not, you can't just like put a kid on a swing for 7 years and like hope for cross your fingers. Like it's not working. So I feel like we kind of need to kind of go a little bit deeper, but and embrace technology. It really is the outcomes we're seeing without negative effects have been really incredible. So yeah.
Is there like a prime age that this would be most beneficial? Like, or is it just, if you have a child and, they're 8 now, and just like you said, like they're kind of feeling burnt out with therapy. Is that too late for a child to
Like look
start
at their
something
airway.
like this? Yeah.
No, no.
Okay.
I mean, no. I mean, I don't really work with adults, but I work with some dentists who do. And like the oldest they've treated is like, I think like 76 or something like that. And the person
Wow.
has sleep apnea.
Okay.
And
Very cool.
she,
So that's super promising for moms
yeah.
to hear.
Yeah,
Okay.
you want to do this as early as possible. It's never, women are more flexible than men, because we give birth and our bodies go through so many changes and our joints and things like that. Men, once they're like in their mid 20s, are kind of like built. So they might require like a more intense type of like jaw surgery or something like that. Women, there's more kind of like room for movement. But no, I would absolutely encourage any parent to not be discouraged by age and to try to get this under control as fast as possible, because you're going to be trying to support your child one way or another, whether it's educational or behaviorally or whatever the outcome is, or just independence. And if you have, if you're working towards something like that and you have this negative impact just chipping away at them every night and they're not sleeping well, it's you're kind of running in circles is how I see it. So,
And it's not like someone wakes up at age 60 and they're like, oh, I suddenly have sleep apnea.
yeah, that's the thing. Yeah, no. And the thing is also is one thing I really when people are like, oh, they'll grow out of it, like in this specific topic of development, they grow into these patterns. That's what I want people to really realize. They're not going to organically just start expanding their jaw. Like that's not what their swallow's been doing likely since they were 6 months old, or maybe even in utero, if they had a tie or something like that. They grow into these patterns, and that's something, and I'm not trying to like fear monger or anything like that. It just is like, these are the rules of physiology. They grow more into what they have done because the brain also likes to take the path of least resistance, and it will do what it's used to. And then your breathing patterns and your diaphragm and all your anatomy start to form around that. And so you'll really, it's not something that you want to waiting and seeing is never the call for this.
Yeah. And the last thing I'll say is you mentioned a book to me, Sleep Wrecked Kids, when we were working together. And I encourage, like, if that's another great place to start too, if you're a mom and your child is mouth breathing, first go look at Dr. Marielly's Instagram and all of her free resources and look at her website, but also read that book because it's a huge game changer.
Yeah, it's a huge, she's so brilliant. I'm blanking on her name right now, but I presented with her at AMPMD. She's so smart, and she's a speech therapist from Australia, and one of the best books that ever for this type of like topic. But also Breath is a New York Times bestseller by James Nestor, and he is an investigative journalist who had like no skin in the game. He just kind of like did a deep dive into myofunctional therapy, and he is kind of who put this on the map, honestly. He kind of exposed athletes to this, and like professional athletes and like the biohacking scene into it. They were kind of already like doing this stuff. And those two books I would say are really amazing. And I actually have my favorite books on my website under my shop, and there's lots of books there. Gasp is another really good one, written by a dentist. And yeah, there's a lot of options for that.
Okay, well, Marielly, I feel like we could talk to you for hours, but we're going to cut it off and hopefully we'll do part two. But thank you so much for joining us today. And you guys, thanks for listening. Check us out and drop your email at www.momsaskwhy.com. Follow us on Instagram at momsaskwhy, TikTok at momsaskwhy podcast. And as always, like, download, subscribe, and leave us a review. We are a new podcast, so it would mean so much to us if you could give us how many stars, whatever you think.
Yeah, absolutely. Thank you for having me, you guys. This is a blast.
Thank you so much, Marielly.
Thank you so much.
Yeah, thank you.